for patients who had mild or recurrent disease, and we are administering the fecal microbiota transplant in an outpatient setting. It's mostly done with the aim to prevent further recurrence. Yeah, I completely agree with you. However, I work with patient population who that are seriously ill, hospitalized, placed in the MICU, mostly because they have also not just severe C. diff, but they have complication due to the Clostridium difficile infection, and considered to be a population that has a high mortality. Current meeting in the ACG of 2014, we also presented our other study that included a total of 17 patients from our institution who were severe or severe complicated. 9 patients had at least one complication of the C. diff infection, including end organ failure, ventilation. 3 patients had toxic megacolon, hypotension requiring vasopressors, who were successfully treated with fecal microbiota transplantation. All these patients were evaluated by colorectal surgeons, and the plan was to remove their colon, and that's when our team was contacted. We very safely and successfully administered fecal matter into the sigmoid colon, and in some instances proximal to the splenic fracture, using careful insertion of the colonoscope with either water immersion or just minimal use of CO2. We did not have any complications relating to the sigmoidoscopy or colonoscopy procedure. 13 out of 15 patients avoided colectomy and had reduced hospital stay or lengths, and were considered to be cured at 3 months when the follow-up occurred. So I considered this groundbreaking news, because we showed in this study, in this pilot study, that fecal microbiota transplant can be used very safely in this critically ill patient population, and leads to a cure compared to colectomy, which is associated with very high mortality of 50%. Our institution, or my fecal transplant program, is transitioning now towards using frozen material because the logistics are quite complex and difficult for using live donors. So there's a huge burden on the patient and also on our office to find either and to screen the patient's directed donor as well as the universal donor. So we are very much looking forward to using a frozen product. And actually the studies done using capsules, as was published in JAMA last week, are very reassuring. Probably the success rate with a single procedure will not be as high, or is not as high as compared to the colonoscopic route or delivery of the fecal process. However, it's easier on the patient, does not require preparation of the colon, and there is no potential colonoscopy-related complications. So I think probably the future is going to be frozen material, which hopefully going to be more prepared to the FDA likings or recommendations, and also to have an option of pills for patients who do not wish to undergo sedation, preparation of the colon, and take the risk of colonoscopy. And I think we will continue to offer the route through colonoscopy, because there are going to be patients who do not wish to swallow poop pills, and there are going to be patients who will be critically ill with ileus when the administration of fecal material into the stomach or into the small bowel, not necessarily the safest idea. I mean, everybody agreed that we should proceed with a prospective controlled study to prove that fecal transplant indeed is superior in the patient population that is severely ill, possibly complicated, compared to the current approach, which is surgical management and colectomy. There are several unknowns and questions that we have to answer. For example, is fecal transplant by itself is a sufficient therapy, or we have to follow the fecal transplant by an antimicrobial therapy such as vancomycin or deficit to achieve cure, which I'm currently implementing. So we also considering performing this study as a multi-center study, so we can recruit patients, a large number of patients, a short period of time, and more investigators can have an input as to how to proceed. But currently, I do not have the right answer. What is the optimal protocol in this severely ill patient population? And also, I would like to mention that Zane Kasan and his team presented during this meeting, or will present tomorrow, a new scoring system called cards that will include certain parameters such as age, inflammatory bowel disease, end-stage kidney disease, diabetes, and so forth, to predict the risk of mortality in this critically ill patient population. So most likely we'll use the scoring system in our prospective control trials. Thank you so much.